What's going on? Thank you so much for checking out this video. And I'm going to give you a quick overview so you can decide whether or not you actually want to sit and read some of the material or you want to watch this video. So the video you're watching right now will go right here on the discussion board. Then we have the presentation handout, which is the one pager right here. We have the infographic, as you just saw, and this is the original article right here. So in the event that you want a deeper dive, but you don't want to read the article, I put a little bit more here than what is on the handout. We got some references, and then we also have some resources down here in the event that you wanted to read the article or look at some of the numbers and better compare them. If you don't have a strong background in statistics, I made sure to put some things here so you can understand the p-value, how it applies to the bell curve and confidence interval, and then understanding hypotheses and how they compare, because all those play a factor into the study. And with that said, before we jump into this, I just want to make one thing perfectly clear. We're talking about investigative research, and it's okay if you have a question that I don't have the answer to in this space. Being able to pursue research as a PhD person, somebody who is a professional 2-year-old in this world. So they apply for grants and they get to have that funding. Portion of it goes to the study, a portion of it goes to a salary that they can live on while they're doing their research. And they get to pursue their passion of answering questions that they once asked why this is the way it is. And I know because I worked with somebody back in 2017, she got a $851,000 grant to fund her 5-year study on online relationships and dating in the computer-mediated communication space. So the money's out there and the lifestyle is there. If that's something of interest to you, you could do these kinds of studies on your own, and you get to pursue it in a passion that you enjoy as long as you're qualified for it and you have a PhD in that space that could probably benefit you. Getting back to the scope of this presentation, if you have a question that I don't have the answer to, that's okay. All right, this is not a patient care situation where, hey, I'm going to try and play Stump Chris. So if you don't have an answer from me for a question that you have about something in the scope or moving forward, that's okay, because that's part of the exciting experience of reading research. You get to form an impression, you get to form a decision based on their data, and if it's something that you can repeat a study on, you can take the study and actually do it yourself. So that's part of the reason that people publish studies, is to try and duplicate it, right? So this is the actual title of the article, Influence of Overcrowding in the Emergency Department. I already know up front, the world of healthcare does not revolve around the emergency room. It's just something that I've been associated with, so this seemed to fit really well. And I was looking for something in the space of computer-mediated communication, interpersonal communication. Those are both my passions, so I was looking for something along the lines of bedside manner, and I came across this, submitted it, got approved, so we're jumping in here. So the prior research was always focusing on why a patient came back to the emergency room. But we wanted to do a quantitative study. I sound like I'm a part of this. The research team wanted to quantitatively analyze to what degree overcrowding influenced return visits, let alone return visit admits. So until now, no significant effect has been reported between the emergency room and overcrowding, leading to return visits of patients. Regardless of reason, they were looking at the quantity, the numbers behind all this. So these are the two guesses they came to, whether overcrowding increases return visits, and then whether or not it influences or increases return visit admits. So I brought this to the idea of the nursing space because there's an undertone when you read this article of whether or not patient care suffers at the initial onset of patients actually coming into the healthcare setting. So when we get to assess a patient, we need to make sure we're doing a high quality job at that. They had 4 points that they assessed the patients in going through the healthcare system, especially at the first 4 hours of their visit, in the first hour, in the fourth hour, as like mile markers, and then the last hour before discharge. So this also implies that we need to manage our workspaces. I imagine we're going to have COVID disappear at some point, maybe someday. And if it's in our lifetime, then we need to make sure that we're ready to handle the amount of foot traffic that can come to and from patient rooms. And overcrowding just compounds that, because now you have more foot traffic who should be getting their own rooms. Sometimes you have hallways filled with beds and patients, and you're trying to figure out a way to help them. They still need and deserve high-quality patient care regardless of what's going on. So prior to exploring this research, my assumption was that last 1 hour before discharge, that's where a lot of errors are going to happen. That was going to result in return visit admits. Why? Well, I have an entrepreneurial mind. I've never been in the business side of healthcare, though. So I acknowledge there's a business component to this. And when you're moving one patient out and another patient in, it's almost like that hotel revolving effect or ambulance effect, where when the bed is empty, you're not making money. So opinions aside about whether or not that's good or bad, you can't disregard that there is a billing side to this. There is a business side to it. My thoughts had changed after I read this, because I started to focus more about the critical errors occurring just like they would in the emergency medical services space. So what makes a good paramedic? It's a good EMT, because both people need to assess a patient and decide what they're going to do. Are they going to stay and play, or they're going to pack up and go? And a paramedic can administer meds to a broader scope than what an emergency medical technician can do. And that's key here, only to the effect of being able to maintain your job and do a good job, particularly in patient assessment, regardless of what's going on and how many critical errors you can do. Especially if a patient's decompensating in front of a paramedic, they still have a job to do, and they're trained to do this, and they're still found, they're human beings. They still make errors. But the goal of this conversation is to try and avoid doing that and understand that overcrowding shouldn't influence that. So we just need to stick to the basics. Patient intake plus assessment can really make a solid foundation of care. So I was looking for something communication-based. That's the word I'm looking for, communication-based. And I remember back in 5 or 10 years ago, medical schools were actually mandating. They found that there was an issue with bedside manner in physicians. So their solution to that was to mandate a sociology class and a communication class as part of their prerequisites for med school. And as we've been entertaining clinicals for quite some time now, the better part of this fourth quarter of the year. And we already know that the best way to get better at something is just to do more of it. Those kinds of classes don't always put you in a situation where you can have better engagement and better dialogue with somebody. Sometimes you're just sitting in a class being lectured to and then having to regurgitate things on a written exam, which doesn't always insinuate that you're actually getting practice communicating with people and having an exchange of ideas. So my emotions and opinions aside of that solution that medical schools had to this, we still need to be able to deliver high quality care as licensed healthcare practitioners, regardless of what's going on in our personal lives, such as birthdays or funerals, whether there's overcrowding going on. And overcrowding is something that you can't disregard if you're not working in the emergency room. So you have hospital spaces that can be overcrowded and start expanding outside of the emergency room if you're in a disaster zone or hurricane hits or something like that. And then with mass casualty incidents, even clinics can be opened and request to be opened, or people who work in that clinic can be asked to come and provide additional staff to Medical Reserve Corps up in Macomb County, or other hospitals that need additional bodies and professionals to accommodate with the disaster that's going on. So don't write that off just because you're not in the emergency room. So now we get to the PhD stuff of PICO, right? And this was a study done in South Korea. We'll talk a little bit more about the patient population in a minute. But with the interventions, they divided things into patient assessment, triage, and discharge. And those were the large groupings that were being appropriated, I guess is the right word, to the sample population to decipher what influenced return visit and return visit admits. So since this was in Korea, they had their own triage scale. It was their version of it. 3 components: arrival time, decision time, and then departure time. So they broke this down into 3 distinct markers, which was the first hour of a patient's visit, the first 4 hours, meaning the 4th hour mile mark, and the last hour that they were visiting. So they broke it down even further because they want to look at the total population, and then they wanted to group and zoom in on whether or not these affected this, whether issues regarding evaluating patients was a factor, or boarding patients, meaning they were already assigned a bed. So they have this fantastic word called crowding indicators in this study. Just acknowledge that there are factors that they applied after taking information from these records of these patients. And that's how they did their best to survey and study how overcrowding may or may not have affected return visits and return visits admissions. So the biggest confounding variable that's coming from the slide with all these words is every study prior to this did not have a consistent definition from one to another on what was determining an overcrowding status of the emergency room or whatever facility they were testing or evaluating. So the idea of overcrowding was common because each of them had their own critical point that they identified to say, yes, we are at capacity and now we're starting to be overcrowded. But as far as the clearly defined phrasing of what it means to be overcrowded, all of them are different. So in statistical analysis, they were comparing the initial visits of patients with or without return visit admits. And then of those return visits, were they admitted or not admitted? And then statistical analysis, again, you can watch the videos later for more information. We were talking about a confidence interval, basically a bell curve. If you're not familiar with that, you got the videos. And then they were also giving adjusted odds ratios to say whether or not demographic information was contributing to there being return visits and return visit admits or non-admits. So they started with a sample population of 6 figures. They whittled it down based on these ideas to this number, took another sample out just in case they had visited in the last 72 hours. They wanted brand new visits. So index visits, initial visits, same idea. So 87,360 patients was their population. 4.3% of that returned to the hospital to get seen in 72 hours. Whether or not that was for the same situation or the same complaint may or may not have been the case. They could have had another complaint and they just ended up returning to the emergency room. This is also in Korea, so we're not sure what their healthcare system is. I haven't been able to figure that out. Maybe it's similar to the United States. I really don't know. But you also have, of that 4.3%, you have 30% of those people who were admitted to the hospital as a return visit. So as healthcare practitioners, you're wondering what's going on. Well, they found that overcrowding for all of the patients at the first hour and the 4-hour mark influenced return visit admission, as well as, where's my marker? Here it is. The patients getting evaluated, the first hour of their getting evaluated, that also contributed significantly. They were statistically significant factors, as professionals in the space say, for getting return visits and return visit admits specifically. So the likelihood increased when there was overcrowding at these points. However, overcrowding at patient discharge reduced the likelihood of incidents of return visits. So to better understand this, they decided that they need to know why the patients returned to the ER. So now for the fun stuff of nursing implications. So there's an undertone here, there's an underlying suggestion that there's an issue with in-processing of a patient, and that could be contributing stress with overcrowding on the healthcare professionals. And I just want to make it clear with a third party here, a third-party study, that healthcare workers are not excluded from experiencing stress or pressure in these kinds of situations, whether the work volume needs to increase, whether you have to be precise in your gig, or you have to be told, whether implied or expressed, that you need to work faster. Even if there's a slight uptick in your stress that you're feeling, it still exists. We're human. It happens. So we have professionals that are licensed at all different levels. And whether or not you're doing the intake or a physician is available and he or she is doing the intake, there's still somebody that needs to triage these patients. So assuming that it's us and assuming that it's our responsibility, we need to acknowledge that stress happens. And we also need to acknowledge that we need to do our part to reduce the risk of return visits. Now, we're human, and I've been saying this. We are not, what's the word I'm looking for? We are not excused. We are not inoculated from doing poor performance with our job. And in the healthcare setting, that can be a dangerous situation. So we need to acknowledge that we're humans. We're subjected to being distracted in our job, but the patient does not care. No emotion or personal event in our own lives should take away from that patient getting excellent patient care. Now, I'm not saying that we're not good at what we do or we're not going to be great at what we do, but in order to really be present in the moment, is a dichotomy here. There are people who suggest that we need to leave our baggage at the door and focus on the patients. And there's another side that says we need to be emotional because our emotion is what makes us a better nurse. At the end of the day, we need to have a healthy balance of both because both are going to affect us. We can't be in one extreme or the other. Maybe some people lean toward one way or the other, but at the end of the day, we need to acknowledge that. We need to acknowledge that we're affected by what happens to us and what we see and experience in the healthcare setting. And as long as we acknowledge that, even with overcrowding, I think we can better be prepared to handle what needs to be done, and we can still go from patient to patient providing that high quality care. Yes, there's a pace. Yes, we're going to have more and more patients coming through, and they all are deserving of our attention and care. But that doesn't mean that we're going to excuse our services to one patient so that another can benefit or another can be seen. So if you stayed all the way till here, you are the lucky recipient of this slide to be told to stay motivated. That's all I got. We will talk to you soon.